I'm Dr. Ajay Yadav. So today we are going to discuss a few very important questions for NEET 2022 anesthesia questions. Uh, First, a clinical case: a 65-year male with history of MI 2 years back, for which he was managed conservatively, is to be posted for laparoscopic cholecystectomy. Latest echo shows ejection fraction of 60%. He is on regular treatment since then. Question number 1 and 2 are applicable to this patient. So important things to note here: that patient was managed conservatively. One thing. Second, ejection fraction is normal. So keeping in these things in mind, let's see the question. Question number 1. Monitoring of which ECG lead is most important in intraoperative period? Lead 1, lead 2, lead V3, lead V5. Why I consider this question as a high yield question? Because there is a major change. Until very recently, we used to believe that lead V5 is best to detect any ischemia. But latest evidence has found that lead V3 or V4 are better than V5. So that's why it become very important as per recent advancement. And obviously if this questions comes, majority of you are going to mark V5, because traditionally V5 used to be considered best lead to monitor ischemia or to detect ischemia in intraoperative period. But now they say V3 is best, then V4, and then V5. So of course, the best lead would be lead V3. But if they ask for arrhythmia detection, then still it is lead 2. So for arrhythmia detection, lead 2 is best. But for ischemia, it is V3 preferred over V4, preferred over V5. Then, but if they ask you that what is the best test to detect ischemia, or most sensitive test to detect ischemia, then most sensitive is transesophageal echocardiography TE. With ECG, you can still miss more than 15% of the ischemic events. But with TE, sensitivity become more than 95%, 95% or 97%. Some studies even say 97, 98%. So majority of the ischemia, they can be detected by transesophageal echocardiography. So most sensitive is transesophageal echocardiography. But T is not that practically possible. So therefore, ECG we are using routinely, and ECG I told you that the best lead nowadays is V3, not V5. Question number 2. Anesthesia is best maintained on oxygen nitroxide halothane, oxygen nitroxide isoflurane, oxygen nitroxide sevoflurane, oxygen nitroxide desflurane. Another very important thing, that it is proven that isoflurane does not causes coronary steel. So this is again very important, because until recently we were believing that isoflurane causes coronary steel, so therefore was not recommended for MI patients. However, latest evidence have found that isoflurane does not causes coronary steel, so can be used for all cardiac patients including MI. Otherwise, you know that a statement about isoflurane was that it is the inhalational agent of choice for all cardiac patients except MI. But now they say isoflurane is the inhalational agent of choice for all cardiac patients including MI. So this is again a very important fact on which you can expect a question directly or indirectly, that isoflurane does not causes coronary steel. Although previously also they used to say that isoflurane causes coronary steel, but more or less it is a theoretical phenomena. But now it is proven that it's not even a theoretical phenomena too. So of course anesthesia will be best maintained on isoflurane in MI patient. Now I change this scenario. I say this patient ejection fraction is not 60%, patient ejection fraction is 40%, means low ejection fraction. Then will you still be using isoflurane or inhalation agents? Of course not. Why? Because all inhalation agent decreases cardiac output. But since the patient's ejection fraction is normal in this scenario, so even a little decrease in cardiac output may be acceptable. And you know that isoflurane among all inhalation agents minimally decreases the cardiac output. So it is considered as inhalation agent of choice for cardiac patients. But if patient ejection fraction is low, like I told you, hypothetical scenario that ejection fraction is now 40%. So here further decrease in cardiac output is not acceptable at any cost. So therefore, in that scenario, if ejection fraction is low, then anesthesia is maintained on opioids, not on inhalation agents. So to conclude, if ejection fraction is normal, you can use inhalation agent, and inhalation agent of choice nowadays, even for MI patient, will be isoflurane. However, if patient's ejection fraction is low, then inhalation agents cannot be used, and in that scenario, anesthesia will be best maintained with opioids. And one more thing I would like to say is nitrous oxide should be avoided actually. So if I would have got another choice, why I'm telling this, because these questions are frequently asked, these kind of questions with different permutations and combinations. Like if I had an option oxygen, nitrous oxide and isoflurane and oxygen plus isoflurane, then I will be only choosing oxygen plus isoflurane, because nitrous oxide, you know, also causes mild sympathetic stimulation, not significant, but it causes mild sympathetic stimulation, and sympathetic stimulation, you know, in MI patient, of course, is not acceptable. Question number 3. A 75-year-old patient who has undergone stenting with drug-eluted stent, I think it is drug-eluted, maybe little not seen, drug-eluted stent 7 days back is posted for knee replacement. Regarding timing of surgery, patient can undergo surgery. Patient can go surgery with high risk, postpone the surgery for 3 months, postpone the surgery for 6 months. This is again very important because there is a major change in the deferral timing of surgeries after MI. After MI, you cannot consider the patient immediately for surgery. Even during first month, the chances of reinfarction is very high. Like if a patient develop MI and you get the surgery done within first month, the chances of reinfarction can become as high as 30 to 40%. So therefore, we have to defer elective surgery. Now, how long we have to defer elective surgery? This depends how the patient was managed. So if a patient has MI, obviously it will be managed by 3 methods. Conservatively, or with stenting, or with bypass surgery, coronary bypass surgery. So 3 method patient would have been managed. If managed conservatively, then we have to defer elective surgery for 2 months. Now, if patient was managed with stents, now the stent may be bare metal or drug-eluted. If bare metal, if bare metal stent is used, which is very rare nowadays. Nowadays, you know, mostly we are using drug-eluting stents. But if managed with bare metal stent, then we have to defer it for 4 weeks. And why I'm making the color to green? Because these are the major recent changes which has happened. Because in books you will find conservatively it is given 6 weeks. It was 6 weeks previously, but now they say 2 months. Bare metal again books you will find 6 weeks, but now they changed to 4 weeks. Drug eluted 6 months. In books you may find 1 year. That was true because previous the stents which were available, their epithelialization used to be complete in 1 year. But the recently available stents, their epithelialization gets completed in 6 months, so you can take the patient for surgery after 6 months. Now, why can't we take patient before 6 months? The reason is if you put a patient on drug-eluting stent, patient has to receive antiplatelet drugs, dual antiplatelets. So if the patient is on dual antiplatelets, that is aspirin and clopidogrel, we cannot take the patient for surgery. We cannot stop them for 6 months because then there are chances of stent thrombosis, and stent thrombosis is definitely more dangerous than MI. After 6 months they say there occur complete epithelialization of the stent, so you can at least afford to stop clopidogrel. Fine, so we have to defer it for 6 months. If the patient was managed with surgery, then the recommendations remain same. Previously it was also 6 weeks, now also it is 6 weeks. Now we can look at a question. Drug-eluted stent and then just 7 days back. So we have to defer surgery for 6 months. Question number 4. A 26-year female suffering from PIH has to undergo LSCS due to fetal distress. Anesthesia of choice: spinal, epidural, combined spinal plus epidural, GA. This is again an important change. For PIH patients, actually we were avoiding spinal. Why? Because they say that spinal can cause sudden hypotension. Secondly, PIH patients, you do expect laryngeal edema, so GA should be avoided. And GA otherwise also should be avoided for pregnant patients, because pregnant patients are so vulnerable for aspiration that the risk of aspiration in a pregnant patient can be as high as 8 times as compared to non-pregnant patients. So GA otherwise should be avoided for pregnant patients, and for PIH patients there is an additional reason for avoiding GA, that these patients may have laryngeal edema, and that intubation can aggravate that edema. So therefore leftover choice used to be epidural, but practically speaking epidural cannot be used in cesarean if it is emergency like fetal distress. Because epidural, the one of the major disadvantage of epidural is that it takes around 15 to 20 minutes to have onset of action of epidural, and you cannot wait for such long period. So epidural may be okay for elective surgery, but not for emergency surgeries like fetal distress. So therefore, in fact, honestly speaking, if you ask me, for almost always I had used spinal for PIH patients, but theoretically it was not advisable. But now theoretically also, literature also suggests that for PIH patients you can safely use spinal anesthesia. Of course, chances of hypotension is more, there is no doubt about that, but you are there to uh, manage that hypotension. So you should be ready hand to manage hypotension, but for PIH patients, you can give spinal. So this is again very commonly asked question, and students are also very frequently asking, because I think recently this question has been asked in some of the exam, and now they expect that you should know that even for a PIH patient, the anesthesia of choice for cesarean section is spinal anesthesia. Fine. Question number 5. A 58-year female is posted for thyroidectomy. She is non-hypertensive for 5 years on irbesartan. Regarding her antihypertensive medication, stopped immediately, dose reductions are required, continued only omitting the morning dose, stop a day before surgery. This is again an important change. all antihypertensives have to be continued except AC inhibitors and angiotensin receptor blockers. AC inhibitors means enalapril, captopril, penidopril, and angiotensin receptor blockers losartan, valsartan, irbesartan. So these medications now should be stopped a day before surgery. Again, in your books, you will find that it is given that they should be omitted on the day of surgery. In fact, there were two schools of thought. Some people say they should be omitted on the day of the surgery. Some people say they should be continued. But more favorable was omitted on the day of the surgery. But recent recommendation says that they should be stopped 24 hours before surgery. Why? If they don't stop them, patient can develop profound hypotension. Studies have proven that. So therefore, now they have to be stopped a day before surgery. D. Rest all antihypertensive we have to continue. Only angiotensin receptor blockers and AC inhibitors to be stopped day before surgery. So I think I'd like utilize this opportunity to just give an idea that which drug should be stopped and which drugs uh, we need to modification. Other than that, all drugs should be considered to be continued. Drugs to be stopped, Viagra or similar drugs, and stoppage time is 24 hours. To be stopped 24 hours before surgery. Then anticoagulants, warfarin, to be stopped 5 days before surgery. Then antiplatelets, aspirin, to be stopped 3 days before surgery, 72 hours, with few exceptions. Clopidogrel, and this is again a very important new change, because in books you will find that it is given aspirin to be continued, but recent evidence shows that aspirin to be stopped 3 days before surgery. Three exceptions are recent MI or patients on already on stents or recent stroke. These are the three exceptions wherever we continue, otherwise we will stop. Clopidogrel to be stopped again 5 days before surgery. Then high dose estrogen to be stopped 4 weeks before surgery. Why? Because you know that estrogen increases the risk of thromboembolism. So to be stopped 4 weeks before surgery. Herbal medications to be stopped 7 days. And again in books you may find 2 weeks, but now they say stopping 7 days is okay to be stopped. Yes, not drug but smoking should preferably be stopped 2 months before surgery, because smoking inhibits cilia and they say ciliary recovery occur in 8 weeks. So to be stopped 8 weeks before surgery. And oral hypoglycemics only stopped on the day of surgery. Similarly, topical creams also to omitted on the day of surgery. Then drugs for which modification is required, and yes, this already I told you, so I did not write it, I'll write it again. AC inhibitors and angiotensin receptor blockers I told you to be stopped a day before surgery, 24 hours before surgery. Modifications are required in insulin regime. I'll not go in details. Steroid regimes and cholinesterase inhibitors. Cholinesterase inhibitors. Other than that, I think if not mentioned here, rest all drugs will be continued. Question number 6. Not a desirable ventilator setting for COVID-induced ARDS. Tidal volume 10 ml per kg, FiO2 80 to 100, plateau pressure 35 to 40 centimeter water, none of the above. Actually, not only COVID-induced ARDS, otherwise also for all kind of ARDS, nowadays most important thing is that we have to go for lung protective strategy. Now they say it is not the mode which is important. It is not the kind of ventilator which is important. It is not the value or price of the ventilator that is important. Important is if you are going for lung protective strategy, then even a 20 lakh ventilator or a 2 lakh ventilator will not make much difference. The important thing is that you have to go for lung protective strategy. And lung protective strategy include the most important thing is that tidal volume should be, I will say, low tidal volume, which by definition means 4 to 6 ml per kg of ideal body weight, not even normal body weight. If the patient weight is 100, that doesn't mean you will be giving 600 ml. What should be the ideal weight for that height? So 4 to 6 ml per kg. Second, plateau pressure should be less than 30 centimeter of water. You know that plateau pressure denotes pressure at alveolar level, while peak pressure denotes pressure at airway level. So it is the alveolar damage which occurs. So therefore we go by plateau pressure. So barotrauma occurs at alveolar level. So therefore we have to continuously monitor the plateau pressure and it should be less than 30 centimeter of water. Secondly, PEEP, that is positive and expiratory pressure. We give positive pressure at the end of expiration. Why? So that alveoli remain open even during expiration and gas exchange can take place even during expiration. Otherwise, the problem of ARDS is that there is a problem of gas exchange. So if you keep alveoli open even during expiration, gas exchange will take place even during expiration. But the problem is all the time if you are keeping intrathoracic pressure positive, so the chances of barotrauma will be high. So therefore, they say minimal PEEP. And minimal PEEP is 5. 5 is minimum. So they say start with 5 mmHg and titrate. So always start with minimum PEEP. So these three things, that is low tidal volume, most important, 4 to 6 ml per kg, or plateau pressure less than 37 and minimal PEEP, that is 5 mmHg. This all will prevent against barotrauma. So lung protective strategy is mainly protecting the lung against barotrauma. Second thing which is seen is that higher FiO2, you know that FiO2, high oxygen can itself can cause ARDS. So therefore they say our aim should be to keep delivered percentage of oxygen less than 60%, or you can say FiO2 less than 0.6. So this is again to prevent lung against the oxygen toxicity. So these are the 4 most important component of lung protective strategy, that is low tidal volume, the most important one, low plateau pressure, that is less than 30, low PEEP means to begin with 5 and titrate, and low FiO2 means less than 0.6, or some studies, some books, they even say 0.5. So again, to tell you, if you are going for lung protective strategy, then your selection of ventilator or your selection of mode does not make difference. So this is very important, lung protective strategy. So not a desirable setting, tidal volume 10 ml not desirable, FiO2 80 to 100 not desirable, plateau pressure 35 to 40 not desirable. So none of the above, none is desirable. Question number 7. Advantage of high flow nasal cannula are all except humidified oxygen, positive and expiratory pressure, increase anatomical dead space, decrease need for intubation. Actually, this HFNC really become very popular during COVID, and in fact, uh, I say it really act as a very filler gap between ventilator and normal oxygen therapy. So high flow nasal cannula, as the name suggests, means we are giving very high flow. And how much high flow? In fact, you can easily give up to even 40 to 70 liters per minute. And given through nasal cannula means given through nasal. If you are giving such high flow, so the most important thing is that gases has to be humidified, otherwise patient will not tolerate if you are giving such high flow. So one of the advantage of high flow nasal cannula will be that you are giving very high flow, so this high flow will create some positive and expiratory pressure. 40 to 70 liter is a very high flow, that will create some positive pressure. So positive pressure means it will provide PEEP of around 4 to 5 centimeter of water. This much PEEP is provided. And secondly, it decreases anatomical dead space. How? Not directly. See, eventually, what is the this is little, I think, difficult to understand for students, that how it decreases anatomical dead space. Not directly, it actually decreases indirectly, we can say. Eventually, what is the end result of dead space? Increase carbon dioxide. So this high flow will wash carbon dioxide from conducting airways. Now whole of the conducting airways are only filled with oxygen. So carbon dioxide has been replaced. So by decreasing carbon dioxide, it indirectly decreases the dead space, not directly. So indirectly it decreases the anatomical dead space. So these are the major, you can say, advantages of high flow nasal cannula: humidified, PEEP, it provides little PEEP, decreases anatomical dead space, and very important is that better tolerated as compared to non-invasive ventilation. So this is one of a very important advantage, that it is better tolerated as compared to NIV. NIV, non-invasive ventilation, you know, we apply tight fitting mask over the patient mouth and nostril, and it is such a tight fitting mask that it causes claustrophobia to the patient. But high flow nasal cannula, you are just keeping nasal cannula, so patient doesn't feel claustrophobic. So that was one of a big advantage of NIV. So humidified, yes. Positive and expiratory pressure, PEEP, yes. Increase anatomical dead space, no. Decreases anatomical dead space. Now decrease need for intubation. This statement should be taken with not only a pinch of salt, I'll say with a tablespoon of salt. And this statement, actually because of this statement, companies with HFNC really could sell their equipment. Now, decrease need for intubation as compared to normal oxygen therapy devices like simple nasal cannula or simple oxygen mask. Yes. But when compared to NIV, I will say no. So that was the catch. Actually, now ideally it is being compared with NIV. Ideally, it should be used as an alternative to NIV. Alternative to NIV decreases the chance of intubation, I will say no. But yes, definitely better tolerated. However, when compared to normal oxygen therapy devices, it decreases the need for intubation. So, like, why I'm telling this, because this question actually has been asked twice and still you can expect this question in any of the exam. Because I have seen a question where they have given decreased anatomical dead space and the fourth choice was decreased need for intubation. So it decreases anatomical dead space, true. Then we have to think that they are comparing with NIV and your choice will become decreased need for intubation. But here we have a choice that it cannot increase anatomical dead space, it decreases anatomical dead space. So we can believe that they are comparing it with decreased need for intubation as compared to simple oxygen therapy devices. Fine. So both of these things should be kept in mind when we are answering this question. So in this, yes, answer will be C. Fine. In this question, if instead of increase, I say choice, I say decreased, then the answer will become D. Question number 8, identify classical laryngeal mask airway, iGel, supreme laryngeal mask airway, ProSeal. This is iGel. It's a kind of laryngeal mask airway, and laryngeal mask airway, you know, they have revolutionized the anesthesia practice. So definitely you can expect a question on laryngeal mask airway. Laryngeal mask airway is this device. This is a classical conventional laryngeal mask airway. So the advantage is that it can be placed blindly. You don't need laryngoscope to place it. Blindly it can be placed in oral cavity so that this cuff part lies in oropharynx. When you inflate this cuff with a large volume of air, this cuff will get inflated and will seal the oropharynx from all sides. When you ventilate through this tube, you can see these holes. Through these holes, air has no option to spill anywhere and it will enter the larynx. So when this LMA was manufactured, it was manufactured as an alternative for failed or difficult intubation. But over the years, when we used LMA, we found it to be so effective method of ventilation that now we are using it routinely even for elective surgeries. So these are the advantages I have seen, and top of that, the biggest advantage of laryngeal mask airway is that you can provide all complications related to intubation, and intubation, you know, has plethora of its own complications. So therefore all these complications related to intubation can be avoided. But the disadvantage, one, this LMA rather increase does not even prevent aspiration, rather increases the chances of aspiration. Why? Because it is not blocking the esophagus, it is just resting over the esophagus. So some air can still leak from the side, can increase intragastric pressure, increasing the risk of aspiration. And the second problem is, even if you are clearly seeing that patient's stomach is getting distended, you cannot deflate also, because from where you will pass your suction catheter Ryle's tube, because cuff has occupied the oropharynx. So that is a problem with classical LMA. But nowadays we are using second generation LMA, and the major advantage of second generation LMA is that there is a separate port for stomach decompression. And you know that the classical example of second generation LMA is ProSeal. ProSeal. Then another kind of second generation LMA, it's not actually LMA, is a brand name. So other company cannot use this word laryngeal mask airway, but they are allowed to use them as laryngeal mask. So similar kind of devices by other company will be considered as laryngeal mask. So iGel is very frequently used. iGel, as the name suggests, means the cuff is pre-filled with a gel, you can see, and it's very commonly used in India. So you can expect question. The cuff is pre-filled with a gel. So all this cuff related problems, like if they accidentally cuff get deflated, what will happen? If cuff get deflated, then chance of aspiration will increase and it will rotate. It itself can cause airway obstruction. And when you are removing the cuff, patient may bite this cuff, damaging the cuff. So all these cuff related complications can be avoided with iGel. And since it is a kind of second generation, so you can see that there is a separate port for stomach decompression. You can see this port. You can pass your suction catheter or Ryle's tube through this port, and through this port, this Ryle's tube or suction catheter will come out of this iGel through this hole and will enter the esophagus. So this is iGel. It is used for humidification, restricting the flow of oxygen, restricting the flow of nitrous oxide, scavenging. What is this? This is HME filter, that is heat and moisture exchanger, HME. And it is used to, conventionally, it has been used to preserve humidity. How? It is attached between breathing circuit and say this is endotracheal tube. So how it will preserve humidity? Say these are the expired gases from the patient. This material is hygroscopic. Hygroscopic means it will absorb water. So from expired gases, all water is absorbed, and in the next breath, the same water will be delivered back. So during expiration, water is absorbed through these expiratory gases, and the same water is delivered back to the patient in next breath. So very simple method of maintaining humidity. So it is used for humidification. But why it really become important in current day scenario, that I have included this as a question, because in COVID time it acted as a filter. So it's not only preserve humidity, it also act as a filter. And that is why it is not only called as heat and moisture exchanger, it also being started to call as HME filter. And in COVID, we were using two filters. One at its position, that is between endotracheal tube and breathing circuit. And secondly, when the expiratory gas tubings attached to the anesthesia machine. So that is why it become very important, because it act also as a filter, and using it, two filters are mandatory in a COVID patient. Question number 10. This is done to ease of oral intubation, ease of nasal intubation, both none. What is this? This is Mallampatti classification. Mallampatti classification, which is done to assess the mouth opening. Which is done to assess the mouth opening, and nowadays we are actually using modified Mallampatti. So this also not new, but yes, I'll say modified is little new, because conventionally we were using Mallam Patti classification, but nowadays we are using modified Mallam Patti. So that makes it more important from recent advancement point of view, number one. And secondly, uh, this otherwise is also very important. So this is done to assess the mouth opening. So what we do, we ask the patient to open mouth as wide as possible, and then by looking at the structure seen, patient has been classified into four categories. So four structures which are seen are faucial pillars, tonsillar pillars, fauces, then your soft palate. Before that, uvula, I'll keep uvula better. And soft palate. Soft palate. In conventional Malampatti, fauces was not the part, only three. That is faucial pillars, uvula, and soft palate. While modified Malampatti, they have added fauces. What is fauces? Fauces is the entry point to the oropharynx. So in modified Malampatti grade 1, obviously all structures are seen. In Malampatti, modified Malampatti grade 2, tonsillar pillars or faucial pillars are not seen, but still you can see fauces. Uvula, if not all, I will say all or at least major part, and soft palate. 3, tonsillar pillars not seen, fauces not seen. Uvula, you may just be seeing the tip, only tip is seen, and soft palate is seen. And grade 4, nothing is seen, not even soft palate is seen. So obviously Malampatti 1 or 2, your oral intubation is easy. Malampatti 3, mouth opening is restricted. That means your oral intubation will be difficult. And in grade 4, there is no mouth opening. So obviously oral intubation will be impossible. So you have to plan nasal intubation. And if that is also not possible, then patient may undergo even elective tracheostomy. So this is done for the ease of oral intubation. A. This equipment cannot detect methemoglobin, sulfhemoglobin, fetal hemoglobin, all of the above. This is what? This is pulse oximeter detecting oxygen saturation and heart pulse rate. So normal pulse oximeter, cannot detect abnormal hemoglobins. So this is one of a very important, I will say, limitation of pulse oximeter, that they cannot detect abnormal hemoglobins. So abnormal hemoglobins can be detected with co-oximeters. So co-oximeters are the special kind of oximeters which can detect abnormal hemoglobin, and that is why these are considered as gold standard for pulse oximetry. So if they ask you gold standard for pulse oximetry, it is not pulse oximeter, it is co-oximeters, because one of the biggest limitation of normal pulse oximeters is that they cannot detect abnormal hemoglobin. So if the patient is even suffering from carbon monoxide poisoning, they will show normal oxygen saturation. So they cannot detect any of the abnormal hemoglobin. Question number 12. The following graph of capnography represents esophageal intubation, recovery of spontaneous breath, cardiac oscillations, bronchospasm. Actually, graph of capnograph is important. I will just give you an overall view of the important graphs. You know that the normal graph of a control breath is like this. So this is the point where inspiration begins. And when inspiration begins, obviously EtCO2 will become 0. And this all is the expiratory phase. During spontaneous breath, so this is control breath. Control breath means breath delivered by ventilator. If patient is spontaneously breathing, the graph pattern will be somewhere like this. Then another graph that you commonly encounter is this. What is this? This is called as curare notch, and this represents spontaneous effort during control breath. So control breath graph is like this, but if you see a notch, what does that indicate? That indicate that the effect of muscle accent has gone. We achieve control breath by giving muscle accent by paralyzing the patient. So if the effect of muscle accent goes, patient will try to take a spontaneous breath, which is represented by curare notch. So this means patient now require another dose of muscle relaxant. Then COPD or asthma, what you expect? In COPD or asthma, expiration is prolonged. So you normally get this kind of pattern. Prolonged expiration followed by inspiration. So this you can say, look at the shape. The graph shape is like shark fin. So shark fin pattern is seen in COPD or asthma patients. Then if you see this graph, that CO2 keep on increasing and it can reach even 80-90 mmHg. This is a graph of malignant hyperthermia. You know that malignant hyperthermia, CO2 production becomes very high, even reaches 80-90 mmHg. And if you go get this kind of graph, where means baseline of CO2 has been shifted, you know. So these are the abnormalities of closed circuit. Baseline shifted means patient is inhaling carbon dioxide, means carbon dioxide is not getting reabsorbed through closed circuit, through soda line. So you find this pattern. And if you find this pattern, CO2 was normal, and then you see there become flat line, no CO2. Flat line means no CO2 is coming out of endotracheal tube. So that will happen if there is accidental extubation. If tube is not in trachea, from where CO2 will come out, you can measure. So it will become flat line and EtCO2 will become 0. Extubation, or if there is complete obstruction. If tube get obstructed by anything, then how will you get CO2? So again it will become 0. Or if there is apnea, if there is no ventilation, how will you get CO2? Or cardiac arrest. When there is no CO2 coming, then when there is no blood coming from periphery, how CO2 will reach lungs, which can come out of your endotracheal tube? So it will become flat line. Now we can look at our question. So this graph represents esophageal intubation. Esophageal intubation, it will become 0. Recovery of spontaneous breath, yes, B. Cardiac oscillation will present like that. Cardiac oscillation will be seen in very lean and thin patients. Means cardiac oscillations will be transmitted to CO2. Graph, capnograph, like this, oscillations. So this will be seen only very lean and thin patients. And bronchospasm, I told you, there will be shark fin pattern. Blue vaporizer is of sevoflurane, desflurane, halothane, isoflurane. Vaporizer, you know, is used for the delivery of inhalation agents. So as far as color are concerned, 4 inhalation agents we are using. So red is for halothane, purple vaporizer color is being denoted for isoflurane, yellow for sevoflurane, and blue for desflurane. So they've asked blue, this one. So this blue is obviously for desflurane, while this yellow is for sevoflurane. That is how you can identify a vaporizer from distance. Untrue. Most commonly used circuit, best for neurosurgical patients. Fresh gas flow is 1.6 times per minute volume, none of the above. First you have to identify the circuit, then only you can tell the characteristics. So rapidly I'll revise circuits. Another very important thing is that these circuits are Mapleson circuits. Circuits may be open, semi-open, semi-closed and closed. You know that